Welcome to Dental XP. Sergio Rubinstein, and the title of the lecture is From Z to A, Parameters for Integration of Aesthetics and Function with Implant Therapy. Modern implant dentistry is more than providing a patient with a titanium fixture and a restoration. When a patient is replacing a missing tooth, it is very important that the expectations are met from an aesthetic point of view, functional, as well as healthy. We are going to determine success by actually, in a reverse pathway, creating what the aesthetics that the patient wants in the first place transfer into the final restoration being a healthy one. To do that, we're going to evaluate here a patient that came to us. She's 46 years old, and she's unhappy with her upper crown, and she wants a long-term, stable, and healthy result. This treatment was started in 2003. What we need to do is connect the dots into what the patient actually wants. In this particular instance, she had an accident when she was 11 years old. And for many decades, they tried to correct this with several crowns. So as we visualize what the patient wants, it is our intent with the technology available to give the patient a restoration where gingival levels happen to be normal and an adjacent and imbalance with the adjacent teeth. So for that, we need to visualize the final restoration, and then we move on to what's underneath. In this particular case, it happens to be a titanium abutment, and we created the correct soft tissue profile with a provisional that is going to allow for that crown to give the proper emergence profile. Underneath, what we had before was a tooth that had to be extracted, and gingival levels were fairly high. In this particular situation, the biggest problem happens to be with the surgeon who has to build up the bone and recreate those gingival contours to what the patient wanted in the first place. This we can see how the patient came to us in the first place. So we can see that the problem was not only an aesthetic one, but a healthy one as well. While the patient declined to have orthodontic treatment, even with this little root, we wanted to do the super option, but that was not a patient's choice. So we move from the original situation into a situation that's now a stable one with the implant-supported crown. This treatment has been something that we provide to our patients for the past 30 years. What did we do before the Brånemark era? We ended up doing heroic treatments, such as root amputations, hemisections, and we did that by actually placing our Superman cap. This type of heroics will be achieved today only on patients that have financial restraints or medical problems. Otherwise, what we recommend is implant dentistry. In this situation, the patient had the lower left molar hemisected as he did not want to have any implant dentistry. The problem is that the path of insertion on the molar is not the same as the one on the premolar. So what we did was a little bit of orthodontics to separate the roots so the patient will be able to maintain a healthy environment. And the final crown happens to be cemented permanently. It was tapped, and we have a T-block that is parallel to the telescopic crown on the premolar. This way we have a restoration where it's permanently cemented and the front segment happens to be screw retained. Telescopic crown is permanently cemented. We were able to follow this case for over 15 years. And while we thought that this was not going to last, it happens to be the treatment of choice for that patient, and just to prove to us that the proper fitting dentistry with proper occlusion could be a long-lasting one. When Brånemark introduced his implant, what we know is that this was actually placed, for the most part, lower anterior jaw, where the bone is the densest. But currently, we apply these implants into individual restorations, and many times we'll place them under the sinus or bone-grafted areas. This is not what Brånemark created in the first place. So we need to know what materials are going to be utilized so they are long-lasting ones. And with the evolution in implants, he did not foresee that the implants were going to be copied into implants that have no anti-rotational device, as we see here with this implant. And many times we did these angulations, the timing on the threads was critical into the final position of the abutment. So implants were evolving to different type of designs, such as the lower molar that we see here, very narrow screw, and these upper screws, different designs, many times them not integrating, or even having restorations that while they integrate, the restoration does not have the profile that we envision a molar should have. And depending on the implant systems, and depending on where the implant is actually placed, we will have different contours. Or sometimes we had restorations where the screw had some loosening, or actually the restoration was cemented prior to actually achieving proper seating of that final restoration. In this particular situation, we have bone loss that is quite advanced, very close to the nerve. So we need to visualize how this is going to be handled in a systematic way to obtain predictable results. In this particular situation, we have a connection with a semi-rigid connection, and there was intrusion of the natural tooth. We also have a cantilever effect. Is this the way we should have planned the restoration in the first place? My suggestion is no, as I do not like to see distal cantilevers. In this situation, the restoration was actually cemented and it was not properly seating. But screws have actually been improved over the last decade, and they happen to have a tougher resistance to fracture. So this is something that we'd like to incorporate into our new restorations. And here we have a slide where we actually see the evolution that has taken place with different implant designs. From the external connection, we have different internal connections trying to prevent screw loosening. And the tolerances that are created by these companies have been so superior that we don't see much loosening of the screws anymore. What's very important is that we also see a healthy environment around the implant. So the soft tissue healing and profile is very critical for a long-term healthy result. When we do restorations that are going to be individual, I still advocate to use torque tightening device, regardless of using an external hex or any kind of internal connection. And even though the components that we utilize today are so sophisticated, and we can have anywhere from titanium to angle components to zirconia abutments that mimic a much nicer natural profile, we must know what type of connection we're utilizing with our implant system. Is this going to be an internal connection that still has a parallel wall versus an implant that's going to have a conical seal? As when we see the conical seal, the intent is to create the forces closer to the center of the implant and actually away from the external and top thread to have a better bone preservation. When we do restorations that are going to be connected, multiple implants as a bridge, I do not advocate the need for actually torque tightening those abutments. When it comes down to bone preservation, it is very critical that we provide the best possible bone preservation for years to come, not just initially. And there are many theories available. Among them, we have the use of external microthreads. The use of external microthreads actually provide a larger bone contact, and the surface area that's going to be in intimate contact with the bone is larger with those microthreads as if it was a larger thread. And this has been presented in many references in the literature. We also have a conical seal abutment, and as we described previously, such an abutment, the intent is to have the forces away from the lateral and external wall on that implant. And this has been again described in the literature. The other advantage of having a conical seal abutment is to try to reduce the micromovement. When we're talking about reduced micromovement, described by Ziprich, he has movies where he describes what the micromovement takes place on a flat-to-flat connection, as we can see on the very first movie. On the very second movie, we also have a micromovement that takes place on a flat-to-flat connection. On the third and last movie here, we have no actual micromovement between the component and the implant. The advantage of having reduced micromovement is actually trying to prevent any bacterial invasion between the abutment and that implant. So with less bacterial invasion, we feel that this is going to help into the bone preservation. It's also been discussed that narrower implant abutment connections could be beneficial. The idea is that, again, the loading forces are going to be closer to the center of the implant and away from the bone level on the most external and top microthreads. Here we have a 3i implant, here we have an Astra implant. The reducing of abutment exchange after uncovering the implant to prevent disruption of the hemidesmosomes, in my point of view, it's something that still needs to be proven, because we have many variations from implant systems to implant systems. And with all those variables, I believe that further research needs to be created, even though the trend is to actually try to minimize changing of components that are going to be at the bone level. So if possible, we would like to place the abutment as a final abutment as early as possible, not to disrupt that connection. When it relates to occlusal design of the prosthesis, we know that in the posterior segment, we would like to have a narrower occlusal table to reduce undesirable lateral stress. We also know that in the anterior area, if we have a very tight anterior guidance, it will be undesirable forces onto that implant and supporting crown. So we like to create a certain movement or allow for the patient to create excursive movements without overloading that implant. When we're talking about occlusion, we're also talking about parafunctional habits. So it's important to know how this restoration is going to be created. Is it going to be in porcelain? Is it going to be gold? Is it going to be acrylic? Again, with bone regeneration, there are many instances that we try to create that bone regeneration as fast as possible. And with earlier loading that we're doing currently with implants, the surface treatments such as fluoride treatment that are placed onto the implant are creating a faster integration of those cells onto the implant. There are different surface treatments besides the fluoride treatment depending on the system that you're using. It could be a Tiunite, it could be Silactive, and that is depending on the implant system of your choice. Advances in bone grafting, it's allowing us to actually place implants in a much better position than we ever could. Prior to bone grafting being as sophisticated as it is today, we had to live with many angulations that were far from ideal from a restorative point of view. So that predictability is quite essential from a good aesthetic outcome. Osteodistraction, where this is going to be done with an osteodistractor as we have here, the RAD5, which is tooth anchored versus a osteodistractor that is anchored onto the bone. The intent is to create orthodontics of the bone and actually superrupt it, move it into a much better position, allow for 2 to 3 months of osseointegration and maturity at that level, and then be able to provide a restoration that's going to be with better profile. Orthodontics, even though we know that the tooth is going to be lost, where it's because of an internal problem such as resorption or periodontal problem that the patient might have had, as bad as this scenario could be, we know that by superrupting a hopeless tooth, in many instances will give us better bone level to the adjacent teeth, improve gingival height, and consequently give us a better result for the final restoration. And try to avoid this type of scenarios. Here we have implants that are actually integrated, but this is not the way we envision to restore this case. And the patient is demanding to have a final prosthesis that is going to be screw retained. So while we're very thankful to the referral guy, we cannot thank him for the problem he has given us. In order to take a good impression, we had to use angle abutments on the upper left side of the patient to create a path of removal of the impression post. So experience is not what happened to you, rather than what you do with what happened. Definitely that should be avoided. As you can see here, technically it's quite a challenge, and the only person that's actually happy with this scenario happens to be my lab technician, because he had to customize all the abutments, and we have through lingual screw retain restorations the prosthesis that the patient envisioned in the first place. So here we have an occlusal view on the model on the final prosthesis, and here we have how this was actually delivered into the patient's mouth. And all this could have been avoided with proper planning. So for treatment planning, we must visualize what the final restoration will look like from the very onset. And as we're gathering our diagnostic information, what we need to do is actually look at every case individually and look at this from every possible angle. The idea is for us to actually integrate knowledge and the diagnosis on a clinical problem with a proper recommendation of sequential treatment for its solution. It is in some instances appropriate to connect teeth with implant restorations. People have different opinions in this regard. Very few people will say yes, it can be done. The majority of people say that no, it cannot be done or it should not be done. So the answer to can natural teeth and implants be connected, Dr. Sheets describes several problems that we see as far as intrusion, especially if we're going to have a semi-rigid connection. Different things can take place as far as the use and atrophy of the natural tooth, and the tooth will actually intrude away from the prosthesis, or debris impaction as one of the several reasons why this is not recommended, or having cement that's actually washed away from the prosthesis. As we can see on the radiograph on the left side, we can see the intrusion on that lower left molar because it was temporarily cemented. Here we have an intrusion because we had a semi-rigid connection. So, if we look at different references with English, he describes different reasons why we have an occlusion with a rigid connection or not a rigid connection. It is my recommendation that if this is going to be connected, an implant with a natural tooth, it must have a rigid connection to prevent the problems that we see on the left side by the natural tooth and coping in actually intruding. Fugazotto and Kirsch, what they showed was there was only 9 intrusions on their study, and that was basically dependent on the fracture or lost screws. So if we're going to connect natural teeth and implants, my recommendation to do is in this fashion. We make a telescopic crown that's going to be milled, tapped onto the occlusal, and the coping is going to be permanently cemented. The abutments on the implants are screw retained. And here we have the final prosthesis where the entire prosthesis is screw retained. The 3 front implants happen to be screw retained onto the abutments, and on the prosthesis on the molar we have a mini screw that's going to be screw retained onto the telescopic crown. This is the final view on the upper arch. And the type of screws that we utilize, you can see the dimensions as we have a screwdriver with the size of a screw that goes into the implant, a gold screw that's much smaller going onto an abutment, and here we have the mini screws that can be tapped and utilized on the prosthesis going onto the coping. We can have a mini screw that is 1.0 in diameter or 1.2 if there was any stripping, and we have a short one as well as a long one. So this is the only way to actually prevent intrusion from the natural tooth and telescopic crown away from the prosthesis. And this could be quite helpful as it relates to proprioception. So again, each case must be closely evaluated. So implant abutment interface, where we have a flat or a conical seal, the recommendation is to have as tight of a seal as possible. So we know that if bone is subject to extreme stress, it will be resorbed. We also know that overloading of an implant is one of the primary factors of the loss of that dental implant. When the interfacial shear stress exceeds the interfacial shear strength, bone fracture and relative movement of bone resorption can be expected to occur, and this is something that we're trying to prevent. I do not recommend to take impressions with triple trays, even though some people do. Here we have an impression commercially, it's not mine, and this is on natural dentition, and you can see that the margins are actually not there. But if a flowable material was going to utilize a lower viscosity, this should have actually been utilized throughout the entire arch to have better occlusion, so the final restoration will not be high when it comes back from the laboratory. When we're talking about implants, in this particular situation we have a vinyl polysiloxane, and we can copy this in a much better fashion by flowing the material throughout the occlusal surface on the entire arch. Accuracy of impression material techniques. We have different studies. And while they found that there was no significant difference between the polyether and vinyl polysiloxane materials, when impression was taken at the abutment or implant level with internal connections, the technique had more accuracy when the splinting of the copings actually took place. Only 4 or more implants with the pickup technique was more accurate than the transfer technique. It is my recommendation to always use an open tray, even with individual restorations. On a different study, what they found is there was greater variation in analog with the transfer technique. Therefore, either the dentist or the lab technician is going to transfer the impression coping onto the impression, this could be a reason to actually create a problem, especially when we're talking about multiple implant restorations. So the rotational errors were large enough to be of clinical concern. So even with a single unit, I do recommend, again, to use the open tray. But they found no significant difference between the polyvinyl siloxane and the polyether material. My material of choice happens to be the polyether. So we need to visualize what the final restoration will look like from the onset. Is it going to be cemented or screw retained? And this we try to determine on our diagnostic phase. We need to know what the aesthetic is going to be, if it's cemented, or if it's going to be aesthetic enough, even if we're going to show metal on the posterior segment. This is all going to alter the position of that implant. Retrievability, if it's temporarily cemented, could be an issue, as this crown could come loose at the most undesirable time or when the patient is on vacation. Today, screw retain restorations do not happen to come loose as they did in the past, and they are easier to retrieve. If the crown is temporarily cemented, as we said, stability could be a concern, and screw loosening happens to be more stable. Concern if cement is completely removed. This does not apply to screw retain restorations. This is a concern for the restorative dentist as well as to the hygienist or periodontist. The cement is preventing proper seating. In some instances, the cement can set before the actual restoration is fully delivered, and this should not apply to screw retain restorations. Ideal contrast can be more easily achieved when the restoration is going to be cemented versus requiring a screw housing for the screw retain restoration. But there's more versatility with the screw retain, as it can be from the occlusal or the lingual. It does require additional lab work and hence additional expense. So even we're doing a single unit, I would recommend the open tray. In many instances, if we have the implant properly placed and the impression post has the correct profile, we may be able to go into the final restoration without having to create such a profile with a provisional restoration, as we're able to do in this particular situation. The restoration is a little bit larger, a little bit lighter, as the patient elected to do some whitening after delivering of the restoration. Impression on multiple implants. It is my opinion, again, between the closed tray and the open tray, to use the open tray, even though the closed tray is the most common one. Especially we're going to talk about multiple implants. One of the previous studies was talking about connecting the implants. This could be through a ligature wire from orthodontics and a resin such as a GC resin pattern. And once the material has set, the impression posts are actually retrieved and the impression copings are embedded into the impression. Easier transfer and more predictable, since there's no need to reposition that impression coping onto the impression. And as I like to have restorations that are screw retained, we like to place composite to cover the access glue onto the final prosthesis. Here we have one way of restoring a patient that had a lower left bridge with recurrent decay, and he would like to have individual restorations. This treatment was started in 2005, and his rationale for having individual restorations was he developed decay underneath the premolar, and he did not want to compromise having another 3-unit bridge and the same scenario to reoccur. So as the root canal was completed, we decided to use the Pureless post. It's a prefabricated post with a very passive fit that's going to be bonded into the canal. We can see how passive this post can actually fit. And we place this under the rubber dam. And in this particular case, we like to use self-curing bonding agents and composite. We did a build-up, and after the build-up, an implant was placed. Unfortunately, in this situation, the lobe should have been on the buccal, but it was straight enough that we were able to utilize a stock component. When we take the impression with the polyether material, we can pour it up to 3 times and still have an accurate reproduction of that preparation in the mouth. And here we can have a solid abutment and understand the relationship to the adjacent teeth without having to section the die. That's why we like to pour up that impression several times. We verify the path of insertion of the zirconia restoration in relationship to the adjacent teeth. We can see that the teeth have been prepared nicely, clear margin. This was done with an electric handpiece. And the final restorations are Procera crowns, which happen to be individual. We're going to the mouth, and again, individual restoration. We'd like to torque tighten the zirconia abutment. And here we have an occlusal and buccal view of the final restorations permanently cemented. In this particular case, we use Fuji Plus from GC. So we can evaluate the initial situation from the patient and final restorations with good adaptation and an implant right in the center. Final aesthetics of the final restoration, and eventually we'll get to work on the contralateral side. The approximate cost of an implant-supported crown, well, we have here the cost of plastic stock tray, impression material, price of gold that tends to fluctuate, custom abutment. If we're going to use a lingual screw retain restoration, it's an additional cost, and the lab cost of additional implant crown. Not having to remove the excess of cement when delivering the crown is actually priceless. It is most of the cases that I like to have screw retain restorations. And another way to restore a lower molar is the one we have here on this patient who fractured a lower right first molar. He would like to replace the missing tooth, and he would like to be as conservative as possible. The treatment started in 2006. As we understand how we restore the previous case, that our options are to have a 5mm implant or 6mm implant. Will this give us the correct profile? Well, we have different options on how to restore this, and as this was described in the literature previously, one of the other options is to actually understand that the loss of the molar left us with room for two roots that could accommodate each one a narrower implant. In this particular case, we're using an Astra system, which is a 4.0 diameter, and we need to respect the distance between the implant and the natural tooth, which should be a minimum of 1mm to 1.5 for both implants. And as described in the past by Dr. Maurice Salama and Dr. Tarnow, they recommended 3mm from one implant to another implant. We need to do further studies, as I believe on implants that have better bone preservation, we could have 2mm from one implant to the other. We have the clinical view from a buccal side with the healing caps, and we can see there's healthy and good distance between the implants, one another, and the implants and the natural teeth. We place here the uni abutment, and we have the restorations connected. Of course, we have the option of restoring this individually, which by far is stronger than the natural tooth. We felt that by connecting them, the chances of any kind of problems, potential problems, will be greatly decreased if these restorations were actually connected, as the patient originally fractured a molar. Here we have the final restoration, and we need to create an embrasure, gingival embrasure, to allow the patient for proper oral hygiene. When we're looking at the occlusal anatomy, we would like the occlusal table to be slightly narrower to prevent any undesirable lateral forces. And here we have a buccal view resembling two premolars versus one molar. The occlusion with the implant, we know that the materials that are selected are going to be transferred desirable or undesirable forces onto the implant and the bone. So we must know what the normal function of the patient is, and if the patient has parafunctional habits, maybe we want that patient wearing a night guard. The materials that are utilized are also very critical. As it relates to disruption of the Hesmith desmosomes when changing an abutment, there are too many variations from one system to another, and this will require further research, as from my point of view, we do not have a clear answer yet. And I think it's possibly that we might be looking at the wrong scenario. We think that we have an answer to something that is just not there quite, because some implants have better bone preservation than others. And this is a theory and a topic that we'll continue to discuss in years to come. Are all implants the same? Well, some people drive a Rabbit and some people drive a Porsche. We know that both cars are German. We know that they both are actually convertible, but we know that they do not function the same way. What we know about implants is that they all work. We also know that the implant design is very important for what we're trying to achieve for any particular instance. The abutments are very important for us to have good knowledge of what's available, and the abutment implant interface is quite critical. The important thing that regardless of what system we utilize is to have excellent bone preservation and ideally soft tissue response. Thank you very much.